Welcome to this webinar series produced by the Commission on Cancer, which reviews the optimal resources for cancer care 2020 standards. This webinar will review Chapter 4. The new standards will be effective January 1, 2020. Please remember that you should address any of your issues into our manual because they will keep you updated on any changes to the accreditation process. There are also new terms defined in the glossary. And remember that there are specific changes to each category of accreditation, so please review the manual. Next slide. You can access the 2020 Standards and Resources page for more information on the standards and upcoming activities, and this is the webinar address for doing so. Next slide. Chapter 4 is a very important chapter which addresses personnel and services resources. Next slide. Patients with cancer have a multitude of needs. Cancer programs must oversee that patients receive appropriate care by qualified professionals. The facility must maintain optimal resources for the care of patients with cancer. And these resources are noted in Chapter 4. The Cancer Committee, as well as others, must develop the criteria to address all of these resources and experience. Next slide, please. Remember that one of the important issues in this particular standard are physician credentials. The multidisciplinary team is extremely important, and they include radiologists, pathologists, surgeons, radiation oncologist, and medical oncologist. All physicians managing patients with cancer must be certified by an appropriate board. These may be boards under the American Board of Medical Specialties, or the American Osteopathic Association, or an equivalent board. Now, it is possible that there are some physicians who have been taking care of cancer patients who are not board certified. You have to demonstrate an ongoing cancer-related education process for all of these individuals to access and be ready to meet this standard, even though board certification has not been given. Next slide. The scope of the standard applies to physicians who care for patients with cancer at your facility and must cover at least 1 calendar year. Now, there may be trainees at your facility, but this does not apply to fellows, residents, or physicians within the 5 years immediately following graduation from fellowship or residency. Next slide. Remember, no longer are we using the Survey Application Record, or SAR. The pre-review questionnaire, the PRQ, must document the roster of board certification status for all the physicians, or must document the 12 annual cancer-related CME hours for physicians who are not board certified. Next slide, please. Now, compliance is very important, and this must be shown clearly both in the minutes of the Cancer Committee as well as in the PRQ. Physicians must be board certified or have an equivalency. And again, physicians who are not board certified must have at least 12 cancer-related CME activities annually. Next slide. The next part of this Standard 4 deals with oncology nursing credentials. And this is really a new variation on a previous standard in our 2016 accreditation process. But remember, this is a phase-in standard. The scope of the standard applies to nurses who have an RN or an advanced practical nurse or physician nurse group. Why is the standard important? The oncology nurses need specialized knowledge and skills. The oncology nurses must hold a current cancer specification certification, or they must earn 36 cancer-related continuing education nursing contact hours. Now, the nurses in the process of cancer-specific certification must provide documentation of progress toward this certification. Next slide, please. There are many ways that nurses can be certified in the oncology world. These could be advanced oncology certified nurse practitioners, advanced oncology certified clinical nurse specialists, advanced oncology certified nurses, or could be certified through blood and bone marrow transplantation certification. In the pediatric area, certified pediatric hematology and oncology nurse certification is appropriate. Certified pediatric oncology nurse certification and certified breast cancer nurse certification certainly is important for our NAPBC and COC programs. There is an oncology certified nurse certification as well. So all of these are appropriate. Next slide, please. Again, the scope of the standard indicates that oncology nursing certification is strongly preferred. There are other nurse certifications that could include cancer-specific criteria, and they may be substituted. For example, a palliative nurse certification with cancer-specific criteria. Remember, the standard is important because 36 cancer-related continuing nursing education contact hours must be shown for each accreditation cycle for nurses who are not certified. This is an important new criteria for our 2020 standards. Next slide, please. And again, remember the roster of nurses that are providing direct oncology nursing care must be shown in the PRQ with their certification status or documentation of 36 cancer-related education hours must be indicated. Policy and procedures that cover your nursing criteria must also be uploaded and evaluated by the Cancer Committee and placed in the PRQ for your site review. Next slide. Compliance is met by showing that all nurses who provide direct oncology care hold a cancer-specific certification or have 36 cancer-related continuing nurse education contact hours. Policy and procedures also must be included. This is extremely important. Next slide. Standard 4.3 deals with cancer registry staff credentials. These are our certified tumor registrars, and this applies that knowledge is obtained from formal education and work experience to complete case abstracting. Now, case abstracting correctly interprets codes, cancer diagnosis, stage, treatment, and outcome information, and should be performed by a qualified CTR. All cancer registry staff who abstract cases at a COC accredited program must either hold a current CTR certification or should perform abstracting under a supervision of a qualified CTR. Now, this applies to program employees or contract groups that provide registry coverage to the institution. Next slide. The scope of the standard in 4.3 indicates that non-credentialed cancer registry staff certainly may work in the registry. They can perform case finding and follow-up, but they cannot perform abstracting on analytic cases unless under the supervision of a qualified CTR, as previously stated. A plan for CTR supervision of non-credentialed staff performing abstracting must be established and include the scope of supervision, the training activities for these non-credentialed staff members, quality control, and the education that is provided to these non-credentialed members. Next slide. Now, the non-CTR staff can obtain and must obtain CE credits. They must obtain 3 hours of cancer-related continuing education that's applicable to their roles, and this has to be done each calendar year. The CE requirement applies to all non-credentialed registry staff, including staff under the supervision of a CTR or those just performing follow-up activities. Registry management or supervisory personnel must be indicated also in the policy and procedure. Next slide. Now, the scope of the standard includes but is not limited to topics in the following areas: advances in cancer diagnosis and treatment, changes in cancer program standards, or changes in data collection requirements. Those providing documentation of credentials and continuing education must have worked in the accredited facility for at least 1 calendar year. This is an important part of the standard. Next slide. Now, documentation must be reviewed on site when you have your accreditation review. There must be verification of the date of the hire for staff to perform case abstracting. And remember again, the PRQ documentation is especially important for this standard. There must be current CTR credentials put into the PRQ for all certified cancer registry staff, as well as non-credential staff, and they must have an indication of their cancer-related continuing education. Next slide. Compliance means that the CTR performs all case abstracting, or the CTR supervises the non-credential staff who abstract. Now, 3 CE credits must be earned annually by all non-credential surgery staff. And it's important for the CTR community to indicate how that CE credit is earned. Next slide. Standard 4.4 speaks to the genetic counseling and risk assessment, which is especially important in our cancer programs. Now, cancer risk assessment includes both the identification of patients at risk for cancer, as well as counseling of patients with cancer. Genetic counseling educates chance of developing cancer in our patients and obtains personal meaning from information, which is important. These genetic discussions will guide and inform decisions about risk, screening needs, and prevention. Next slide. The scope of the standard shows that the policy and procedure must address the mechanism of cancer risk assessment, genetic counseling, genetic testing services. Now, service availability, whether on-site or by referral, is indicated in this standard. Referral relationships to other facilities and local agencies must be clearly stated in this standard. The policy and procedure should include criteria for referral for genetics evaluation if genetic evaluation is not on-site, identification of the genetics professional who is available, and identification of the genetics professionals who are qualified to perform post-test counseling. Next slide. Now, who should perform this work? Well, specialized training does exist in cancer genetics and is required. There should be a genetics professional with an educational background in cancer genetics and hereditary cancer syndromes. Now, just in our discussion of the nursing education and certification, there are certain genetic professional groups which also give special certification for genetics training. These consist of the American Board of Genetic Counseling, the American Board of Medical Genetics and Genomics, Advanced Practice Nurse in Genetics, Advanced Genetics Nurse Certification, Advanced Oncology Certified Nurse Practitioner, advanced practice oncology nurse, registered nurse with specialized education in genetics, physician assistant with specialized education in genetics, and physician with experience in genetics and ongoing certified education in genetic counseling. Now, it's important to recognize that you don't have to be a genetic counselor to offer this process as long as you are covered by one of these areas. Next slide. In this particular standard, the process addresses the genetics assessment for all relevant cancers. And many, many cancers are coming into this area which require genetic counseling. There must be use of evidence-based national guidelines for genetic assessment for a specific cancer site. So again, the NCCN guidelines or other guidelines apply. Now, what are the responsibilities of the Cancer Committee? Well, the Cancer Committee must review the policy and procedure for all genetic assessment and referral for genetic evaluation and counseling. They should review the number of patients identified as needing referrals for the selected cancer site annually. They should review how many patients received a referral for genetic counseling and document this review clearly in the minutes and document the review each calendar year. Now, if available, genetics professionals should attend the Cancer Committee meeting to lead the discussion and provide the report, although this is not mandatory or required, but certainly is an important step in the genetics discussion. Next slide. Again, the PRQ should clearly include the policy and procedure for cancer risk assessment, genetic counseling, genetic testing services, which are either on-site or by referral, and of course, should include the Cancer Committee minutes, which very clearly states when the genetic program is discussed and how genetic counseling and risk assessment services are offered by the facility. Next slide. Compliance means that cancer risk assessment and genetic counseling and genetic testing is provided to patients on-site or by referral. Genetic counseling and risk assessment policies and procedures must be in place and reviewed annually. The process must follow the evidence-based national guidelines, and the process must be evaluated annually and must be clearly stated in the Cancer Committee minutes. Next slide. Standard 4.5 discusses palliative care services, which are extremely important in any facility. Now, palliative care is an essential component of cancer care. It optimizes the quality of life. It begins at the diagnosis and is continuously available throughout the treatment process and surveillance of any of our cancer patients, and when applicable, during bereavement. But remember, palliative care does not equate to hospice. Palliative care is ongoing for all patients and must be available on-site or by referral. It has to be available to all of our patients with cancer and should be available to family members as well as caregivers. The process of palliative care must be evaluated at least once each calendar year by the Cancer Committee. Next slide. Now, the scope of the standard is important because palliative care is provided by evidence-based national guidelines, which include a palliative care team and a way of providing consultation to all of our patients who are in need for cancer care. It is recommended that the following specialties participate in providing palliative care services, and certainly this includes physicians, our advanced practice providers, our nurses, our mental health professionals, social workers, and spiritual counselors. Next slide. The scope of the standard involves the integration of all palliative care into a continuum of care for our cancer patients. Now, there are various types of palliative care services. These are not limited, but should include team-based care planning, pain management, communication, education, assistance with medical decision-making, continuity of care, attention to spiritual needs, psychosocial support, and of course, bereavement support. Next slide. The scope of the standard, again, may involve on-site as well as off-site palliative care services, and this has to be clearly stated in the discussion of palliative care by the Cancer Committee and the minutes generated. The palliative care team must be available on-site, and criteria for referral to a palliative care specialist must be clearly stated. Palliative care services that are not provided on-site must be provided through a referral relationship, just as other standards are noted in a referral situation. These could be to other facilities or to local agencies that provide palliative care services. Now, each calendar year, the Cancer Committee must evaluate the palliative care process. They must monitor the process, evaluate how effective it is for the cancer patients, make recommendations for any improvements to the palliative care service, and of course, document this very, very clearly in the Cancer Committee minutes. Next slide. The scope of the standard must assess the approximate number of cancer patients who are referred for palliative care, and also discuss what triggers the referral to a palliative care group or specialist. And then, of course, discuss any areas that how we can improve our palliative care process. If available, it is also recommended that the palliative care professional be available at the Cancer Committee meeting when the palliative care process is discussed and the report is made and the minutes are taken. Next slide. The pre-review questionnaire must document clearly the policy and procedure for palliative care, whether it's on-site or by referral, and the Cancer Committee minutes must be clearly stated and uploaded for the site review when it occurs. Next slide. Now, compliance is based on the services that are available, either on-site or by referral. The palliative care policy and procedure should be reviewed annually, and the process must be evaluated and clearly stated in the minutes as all other standards are. Next slide. Standard 4.6 involves our rehabilitation care services. Now, rehabilitation care is an essential component of cancer care, and that's why this has been replaced and put back as a standard in the 2020 standards. The interventions could be preventive, restorative, supportive, or palliative. They must optimize a patient's functional status and the quality of life. And remember, rehabilitation really begins at the time of diagnosis and is a continuous process throughout treatment, surveillance, and when applicable through the end of life. There are several rehabilitation professionals who are associated with cancer rehabilitation, and they should include, but certainly are not limited to, physiatrist, physical therapist, occupational therapist, and therapists dealing with language and speech pathology. Next slide. The scope of the standard should include what's available on site in our accredited institutions or by referral. Now, the types of rehabilitative care services may include, but are certainly not limited to, the screening and diagnosis and management of the physical problems that our cancer patients might face. These are dysfunctional problems, impairments, and disabilities. The interventions to manage these functional impairments must be clearly outlined. Screening, diagnosis, and management of pain and non-pain symptoms is extremely important for cancer patients. And then, of course, screening, diagnosis, and management of cognitive functions, especially for patients receiving chemotherapy. Lymphedema management is important, as well as physical activity recommendations during and after treatment. For patients with head and neck cancer, vocal rehabilitation is an extremely important part of our rehabilitation services. Next slide. Now, the scope of the standard should be defined and reviewed by the Cancer Committee and should be clearly stated in the policy and procedures, just as other standards are. This should involve what's available on site as well as off-site rehabilitation services. Who makes up the rehabilitation care team? What are the criteria for performing functional assessments? And what are the criteria for referral to a rehabilitation care specialist? Now, each calendar year, the Cancer Committee is responsible for monitoring, evaluating, making recommendations for improvements in the rehabilitation care of our cancer patients, and reviewing any recommendations and improvements and document these clearly in the Cancer Committee minutes. If available, it is recommended that a rehabilitation professional should attend the Cancer Committee meeting to lead this particular discussion and provide information for this report. Next slide. As our other standards clearly state, the PRQ must be populated by our rehabilitation services policy and procedure, should include all on-site services that rehabilitation provides and any services by referral. The Cancer Committee minutes should document all of these activities and be clearly stated for uploading into the PRQ. Next slide. Compliance involves what's available on site as also by referral. And remember, as our other standards, the process must be evaluated annually, and the Cancer Committee must be clearly involved in the documentation of the process. Next slide. Standard 4.7 involves oncology nutrition services. Now, oncology nutritional services must be provided by a registered dietitian nutritionist, or RDN. What defines the RDN? Well, the RDN has specialized knowledge and skills and is uniquely trained for the nutritional problems that our cancer patients face. Oncology nutrition services, policy and procedures must guide the referral to appropriate services, and these again can be on-site or by referral. The process and policy should address the nutrition and hydration requirements and recommendations throughout the continuum of care, not only for inpatients, but also for outpatients. These should include prevention, diagnosis, the treatment of our cancer patients, survivorship care, and palliative care services. Next slide. The scope of our oncology nutritional services should be well defined and identified both on-site and by referral for our cancer patients. Now, these components of oncology nutrition may include, but are certainly not limited to, the screening of our patients regarding their nutrition assessment, our medical nutrition therapy, nutrition counseling, nutrition education, both for patients and caregivers, and management and coordination of enteral and parenteral nutrition. Next slide. The standard of care should involve and clearly state whether nutritional services are available or not available at our institution, and clearly state where referral services are available, if not at the hospital setting. Each calendar year, the Cancer Committee, as in other standards, must monitor and evaluate the nutritional process and must make recommendations for improvements to any on-site nutritional process and hydration service for our patients. They must review any recommendations for improvements and document these clearly in the Cancer Committee minutes. If available, it is also recommended that the nutrition specialist should attend the Cancer Committee meeting and lead the discussion when this is reported to the Cancer Committee. Next slide. The PRQ documentation should clearly state the oncology nutritional services policy and procedure and be available for the site review when on-site services and referral are reviewed by the on-site reviewer. These must be provided by the registered dietitian. The Cancer Committee minutes must clearly document this on an annual basis for review in the PRQ. Next slide. Compliance, again, as in other standards, indicates that oncology nutritional services must be provided on-site or by referral, and this is reviewed annually and clearly discussed by the Cancer Committee. Next slide. 4.8 covers our survivorship program. Now, survivorship programs must meet the needs of cancer patients treated with curative intent. Now, classically, this has involved our stage 1, 2, and 3 patients, but remember there are patients with stage 4 disease who are effectively treated for long-term by endocrine therapy and other methodology, which should be included in our survivorship programs. The Cancer Committee must oversee the development and implementation of these programs, and it's extremely important to have a coordinator of the survivorship program elected by the Cancer Committee and clearly stated in the Cancer Committee minutes. Next slide. Now, what's the scope of our standard? Well, the survivorship program coordinator must develop a survivorship program team. Who should make up this team? Well, it should be made up by physicians, advanced practice providers, nurses, social workers, nutritionists, physical therapists, or any other allied health professional who the institution deems is important for making up the survivorship program. The survivorship program team must determine the list of services and programs provided for survivorship, and this must be formally documented. A minimum of 3 services offered each year. This is a new process involved in our 2020 standards. Next slide. So each year, the survivorship program coordinator must report to the Cancer Committee on the activities of our survivorship program. They must include an estimate of the number of cancer patients who participated in the 3 identified services, and must identify the resources needed to improve the services if there are barriers existing at the facility for survivorship care. Next slide. Now, the survivorship program could include a myriad of programs. This slide indicates many of the different programs that could be included for the 3 programs in this process. Could be screening for new cancers, financial support services are important, they might be psychiatric services, or maybe seminars for survivors or caregivers. So it's important that the institution itself and the survivorship team develop the 3 programs that are followed by the survivorship and included in the survivorship process. Next slide. The scope of the standard shows that the COC recommends and encourages that patients receive a survivorship care plan, but remember, this is not a required component of the new 2020 survivorship standard. Delivery of survivorship care plans may be utilized as one of the services offered to survivors, but this is not a requirement. Now, if survivorship care plans are offered, then the institution and the survivorship care team must define the population that will receive these survivorship care plans. Next slide. The pre-review questionnaire, the PRQ, must clearly document and include the policy and procedure for our survivorship program, as well as the discussions included in the Cancer Committee minutes. Next slide. Compliance is based on identification of not only a coordinator, but a survivorship program team, which is led and designated by that coordinator. The process must be evaluated annually and must be included clearly in the Cancer Committee minutes. This includes and concludes our review of standards in the Chapter 4 of our 2020 standards. Thank you.